what can we do in patients that have progressed on sorafenib or are intolerant to sorafenib? So far, we did not have too many options in our daily clinical life. One important point is here whether the liver function of our patient is still good. And I think this is what we have really learned in the last 5-10 years with all the negative second-line trials we had, unfortunately. But they clearly told us that if patients that have progressed under sorafenib, if they have a good liver function, they still have a reasonable life expectancy of around 7 to 8 months. So it's worthwhile to really invest here and try to introduce new second-line therapies. We do not have an approved second-line therapy available at the moment, so we are trying to find options. One option, of course, is always to include patients in clinical trials. Outside of clinical trials, it depends. Today, we do have evidence from recent trials that some drugs might work. For example, ramucirumab in patients with high AFP levels. We have quite promising data for patients that are treated with immunotherapies. So here we can kind of discuss with the health providers whether we can use any of these potentially active drugs with our patient even outside of clinical trials. But this is clearly something we should not recommend on a general basis. And it's clearly a great problem we still have for our patients that are in good performance status with good liver function.
We've been trying for a long time to improve on sorafenib's activity in the first-line setting of liver cancer. To date, no agent has been shown in phase 3 studies to improve survival more than that we've seen in sorafenib. And you could argue the larger unmet need is in the second-line setting for patients who have been on sorafenib and then their disease is progressing. There's been several phase 3 studies that have been looked at. One of the first studies to read out was with brivinib, a VEGF, FGF small molecule inhibitor that looked very promising in a single-arm phase 2 study, and actually in phase 3 did not meet its endpoint versus placebo. Since there's nothing approved in the second-line setting, the standard of care in the control arm for the phase 3 studies has been placebo. The mTOR inhibitor everolimus was evaluated in a phase 3 study, again, based on some promising biological insights into the importance of mTOR signaling in liver cancer. But unfortunately, that study was negative as well. And ramucirumab, the monoclonal antibody to vascular endothelial growth factor, was evaluated in the second-line setting versus placebo in an all-comers population. And again, unfortunately, that study was negative for improving overall survival. Interestingly, in that study, in a retrospective analysis, there looked to be perhaps a benefit in patients who had a high baseline alpha-fetoprotein. And now there is a new prospective study, the REACH2 study, which is evaluating ramucirumab, but only in those patients with an elevated AFP. There are other ongoing phase 3 studies in the second-line setting. Tivantinib, which is a small molecule inhibitor of the c-MET kinase or hepatocyte growth factor receptor, was evaluated in second-line versus placebo in patients who have high c-MET in their tumor based on immunohistochemistry. That study has completed accrual, and we're waiting for results. And similarly, cabozantinib, a c-MET VEGF multikinase inhibitor, has been evaluated in the second-line setting in phase 3, and those results are awaited as well. Lastly, regorafenib was evaluated in a phase 3 study, a multikinase inhibitor that showed some early activity in a single-arm phase 2 study. This data was presented recently and was a positive study, the first positive study to show a benefit in second-line liver cancer.